Do you have clients who experience pain with sitting or having a bowel movement or who have trouble activating their pelvic floor? Well, working with the Ischiorectal Fossa can help alleviate these issues. In today's episode, I talk with Nicole Cozean, and we have a fabulous conversation talking about the Ischiorectal Fossa. Listen in to learn what signs and symptoms restrictions in this area can create. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Hello, everybody, and welcome to this episode. I am just so excited to have with us today Nicole Cozean. Nicole is a physio. I'm thinking of talking to an Australian, but
Well, your reach might be international, Lynn, so let's go with it. I'm a physio.
you're a physio and a physical therapist out in California. She's the owner of Pelvic Sanity. She is also the co-founder of PelviCon, which just sold out in 29 minutes again this year. Congratulations on that.
Yay, thank
Yeah.
you.
Well, thank you so much for being here, Nicole. I so appreciate your time.
Yes, same. I'm excited. And for those of you who want to listen to Lynn on my podcast, that also aired a couple weeks ago now. But yeah, like this is great. So make sure you check that out as well.
Oh my God, that was so fun. You and Jesse do such a great job interacting with your interviewees, and I just had so much fun with that. So thank you for that honor as well. Nicole, I'm just super excited about our conversation today because it was a podcast that I listened to that you did with Jesse on the IRF. And I have to say, I was so confused about this IRF because I think I called it in one podcast the interrecti fascia or something, and the intra, and then I'm like, oh, it's ischiorectal fossa. And I was like, you were talking about it on your podcast, and I was like, what is this? Like,
Yes.
it wasn't even on my radar before listening to that podcast. So, number one, thank you for bringing it to my awareness and for teaching us all about the IRF. That's going to be our topic today, everybody, because it is so incredibly important.
Yes, profoundly important. And, we were chatting a little bit before we actually started to press record on this podcast about, where did we learn about this stuff? And I know, Lynn, you did your pelvic health training, a long time ago, and I did it
Before Herman and Wallace.
right
So
before, right?
I actually trained one-on-one with Kathy Wallace. So we were both working for the same company, and they wanted me to start a public health program in three other clinics. And so they hired Kathy to train me one-on-one. So I'm like, and we all know that when you go to courses, you only learn 20-30% of what is taught in that course, unless you review within 24 hours, everybody, then you go up to 30%. Did you know that?
I
Reviewing
did not know that, but I mean, again, you just don't retain that much stuff. It's
it.
just like information overload, right?
Absolutely, absolutely. So, but when I was listening to this, I was like, wow, did I miss this? Like, did Kathy not talk to me about the IRF, or did, like, is this being taught? So, Nicole, how did you learn about the IRF?
It's interesting. I don't know exactly, but I can tell you a little bit of the progression. So I I did my clinical public health coursework with Kathy Wallace and Holly Herman when they were teaching with Herman and Wallace, when they owned it. And that was like 2006, 2007. I was like a baby clinician. I had just graduated from PT school. I didn't even really know if I wanted to do pelvic health. So even if it was taught back then, I certainly don't remember
Yeah.
it being a big thing. But when I had a really awesome orthopedic mentor, and about a couple of years into my pelvic health experience, I had a really awesome pelvic health PT mentor, and both of them in different ways talked to me about the ischiorectal fossa. We'll go into the anatomy and stuff in a second, and where it actually is, what is in it, and why it's important. But each of those people helped me to really understand its significance, and they both treated it in a different way.
Okay.
Um, yeah, and so the cool thing about this region of the body is that you can access it externally. You can access it with someone's in supine, you can access it with someone in sideline, you can access it with someone in prone. And so it really is a pretty ubiquitous region, or a way that you can access it very ubiquitously throughout the body. And so I really feel like it's great for people that have a lot of pelvic floor dysfunction, pelvic pain, that can't tolerate an internal exam. There have been many times when a vaginal exam has been too painful to attempt to do, and I work there, and then you go back and do it, and it's like night and day. So that's where I originally learned about it, was both from, kind of an orthopedic mentor and a pelvic health mentor that was very much focused on this area. And then over the years, I've just developed some of my own techniques around it. It's an area that I never miss on an evaluation. And it's an area that I feel like is extremely important for kind of anybody that is coming into your clinic. And we can go into each of the different diagnoses and why it might be important for them. But yeah, it is just one of these places that it holds a lot of tension, and it holds a lot of it can hold a lot of dysfunction. And so let's talk about what it is actually. So
Tell us the
yeah.
anatomy of it.
Yeah, so the ischiorectal fossa is basically the space between the ischial tuberosity and the perineal body. And that essentially it's like an area that's very high in fatty tissue. So you kind of think that it's just this squishy area that doesn't really have anything in it, that's sort of insignificant. It's sort of like butt cheek adjacent, gluteal fold adjacent.
Yeah.
And I think you could very easily just be like, oh yeah, that's where someone's, gluteal fold is. But when you actually look at it on an anatomy, then we can actually talk about what's the contents that are in it and why it might be actually helpful for pelvic floor.
So when you're talking about that space between perennial body and ischial tuberosity, are we talking at the level of the transverse perennial body? Are we talking about above it, below it, all of it?
It's
What do you?
slightly inferior to that, but it takes up a decent amount of space
Yeah.
too. So it the way that I palpate it to start is that, yeah, I palpate ischial tuberosity and go just medial to that. And then with your thumb sort of in a C sort of shape, um, you can palpate it if someone's in supine, but you can also palpate the ischial tuberosity if someone's laying in prone, and go medial to that, and also come where like the intergluteal cleft is, or the butt crack, right? And it's also that area as well. So it's kind of like if you were to imagine the letter C hooked up medial to the ischial tuberosity, it's sort of in that whole space.
Okay. Yeah. That's I use it as I kind of have this protocol that I do when I'm doing intravaginal work, and just, like check this area, then check this area. And one of the last pieces is my external anal sphincter is a muscle that I will assess. And then I go lateral to that. And,
Right.
so lateral to the EAS, medial to the ischial tuberosity, and then I'm pressing up in there and really kind of getting a sense of what those tissues are on either side. But just like you said, you can assess it. I mean, that is done externally for me at that time.
Yep.
But I love that you can, we can do it in prone, we can do it in side lying, we can do it in hook lying, like you can access this point without doing internal work. And
Yeah,
so,
and so to your point, Lynn, I would call what you just described like lateral to the EAS, medial to the ischial tube. I would call that the posterior ischiorectal fossa.
okay,
Um,
that's what I
and
was
then you can
trying
also,
to, yeah.
yeah, so I would call that the posterior ischiorectal fossa, and then the anterior ischiorectal fossa would be like um, perineal body adjacent, just inferior to the superficial transverse perineal, that way, which is best, I think, best looked at supine, um, where you can actually sink your, and what it should feel like, right, is that if you palpate the ischial tuberosity and go just medial to that, you should be able, and I usually use my thumb, um, to just gently press into that tissue. Should feel like you can sink really far into that tissue.
Yeah.
So some of it is where you can actually sink really far into that tissue, and you would actually hit some of like the um, I'm sorry, the iliococcygeus, right? That's where you would also be palpating some of that posterior pelvic floor, posterior levator ani. So there's that, but the more superficial part of that is what this ischiorectal fossa part is. And in that area, because it has it's essentially a fatty tissue, but it also has fibrous bands that extend from side to side that really allow the distension of the anal canal during defecation.
Oh,
It's
okay.
important for it to be um, very pliable during birth.
Mm.
And for all of the excursion that the pelvic floor has to go through, both for relaxation and a bulge, and then it has to be able to contract back up for a proper pelvic floor contraction. Like, it is really an important area that is also subject to a lot of inflammation because it's also right where you sit, right? So if you think about
Wow.
the actual tripod of coccyx and ischial tuberosities of the weight-bearing structures, you're essentially sitting right on your ischiorectal fossa as well. And so that can be a source of pain in and of itself. It can be a source of inflammation, and therefore it can be a really an area that's just ripe for subcutaneous paniculosis, which is that inflammatory cascade that creates that really icky feeling of superficial fascia that needs to be healthy and worked on with for to improve blood flow, decrease inflammation, and help the underlying musculature that's there work better. And so that is just an area that is really important. And the other really important piece, Lynn, that I think that most people forget about is that it is an area. So the contents of the IRF, like I said, is fatty tissue. It also contains the inferior rectal artery, nerve, and vein.
Okay.
And it contains the pudendal nerve, artery, and vein, which after it travels through the Alcock's canal. And so it's one of those areas that as we kind of have the distal portion of the issue of the pudendal nerve coming out in those clitoral, perineal, and rectal branches, that is where it's actually coming out superficially. And it can be a source of irritation, inflammation of that can create pudendal nerve-like symptoms, so pain with sitting and that kind of stuff. But it can also restrict blood flow to the pudendal nerve,
Oh,
which we know now, if you think about where the pudendal nerve innervates, it innervates some of the sphincters, it innervates some of the levator ani. And so now all of a sudden it's like super important for that area to be healthy so that there's good blood flow to a lot of the pelvic floor structures that we need for all of our pelvic floor health.
well, and something that stuck out the most of what you said there, Nicole, was the ability of that rectum to be able to expand. So if we've got pain during defecation, we need to be assessing this IRF. We have pudendal nerve. We need to be assessing this IRF. We have, anything going on superficially deep with the pelvic floor muscles.
Yes.
Like you said, this area is so critical that we make it mandatory on everybody that we're doing pelvic floor work with.
Yes. And the other thing that I feel like a lot of people forget about its function there too is that as you're learning about this, it's like all of those things good, right? We need to assess that to see about blood flow and inflammation and subcutaneous paniculosis and pudendal nerve health and all the things. And also the health of and sponginess essentially of that tissue helps to support the rectum. So in somebody with a rectocele, for instance, as well, it can
Yeah.
also be an area that if it's not pliable and movable and healthy tissue there, that it can be an impedance to that area and also significantly impact the feeling of prolapse, especially in a rectocele situation. So I'm not saying that treating there can make a rectocele better necessarily, but it certainly can be a symptom reliever
Right.
for extra pressure that is happening from a rectocele perspective. And it can actually help support that, especially for those low rectoceles, which are really, difficult to treat.
Yeah.
They're uncomfortable for patients, and pessaries aren't really shown to work that well for that
Yeah.
type of a low rectocele. And so a lot of times someone that has that feeling of heaviness and rectal pressure and difficulty with defecation because of a rectocele, working on that area, first of all, you'll find a lot of dysfunction there. And secondly, when you actually release that area, you are helping to support the posterior vaginal wall structures of with someone with prolapse.
Okay, so to me, this makes so much sense when with a bowel movement, something's got to expand, right?
Mhm.
The stool comes through, the tissues have to expand. So if the IRF, if that area of the pelvic floor does not expand, then that stool, the rectum, is gonna have to go more anterior and
Yep.
create more of a rectocele. And so
Yes.
if we can release that, because I've always been amazed because we know like there's no treatment for that inferior rectocele, but yet I have had clients come in after doing all the work that I do on the EAS and the IRF and all that area. They're like, yeah, I'm better.
Right.
Or it comes and
Right.
goes more, right? It's like it's not constant.
Right. And I think you bring up a great point there. And this is what I feel like all of us public health rehab providers know, but sometimes we can't translate into real world stuff, right? We know that we learn that the severity of prolapse, anatomical prolapse, and the severity of symptoms don't necessarily correlate, right? Meaning that you can have a low grade prolapse, but really high symptoms and symptom bother. Opposite, you can have someone who has a grade 3 prolapse, it's at the freaking introitus, and they're
Yep.
like, I have a prolapse, right? No problem.
Yeah.
So we know that. But people that have symptomatic rectocele, remember that a patient doesn't know all the anatomy there. They feel pressure, they feel discomfort, they feel something lower. And a lot of times it can be some of those symptoms can be from an irritated ischiorectal fossa connective tissue problem that is actually creating those symptoms. That the rectocele itself, especially if it's a low grade, like 1 or 2, is actually not problematic. But then they go to their OBGYN, they see, oh, you have a rectocele. Now those two things are correlated in the patient's brain, but it's our job to sort of dissociate those two things and be like, yes, you have a rectocele and you have dysfunction in this area. Well, let's see where the symptoms are actually coming from. And if we treat there, a lot of the times, not only do we improve defecation mechanics and blood flow and help around the pudendal nerve and all of that kind of stuff, but we can also create a place where the symptoms of that pressure or pain even, um, that worsen there, those things can go away if we treat. And then now all of a sudden their grade 1 or 2 rectocele isn't as big of a problem anymore as they thought that it was. And so it's just such an area that I feel this needs to get addressed,
Yes.
especially for someone with prolapse, and then also like in those other areas that we talked about as well. Because the same thing can be said for pain with sitting. You have someone that has pain with sitting, you automatically think, oh, this person must have pudendal neuralgia or some other sort of issue. And when we actually do our eval to like look at, well, what is the pain generating tissue here? Sometimes I can reproduce someone's exact pain with sitting by palpating in the ischiorectal fossa. Same thing with like some introitus pain or entrance dyspareunia.
Hmm.
A lot of times it's because that area isn't able to um, relax and descend and have enough elasticity in it, so that that's actually impeding the perineal body and the introitus between 4 and 8 to expand. It has nothing to do with the pelvic floor part. It has everything to do with that tissue in there. You treat that, you try to insert a dilator, or they go home and they try to have penetrative intercourse and they're like, oh my gosh, I'm so much better. That's the kind of the power of working in this area. And so I really feel like it's important to really do a thorough assessment and not just assume that every single thing is pelvic floor muscle related, that
Mhm.
there's perineal fascia, there's ischiorectal fossa, there's ligaments, there's the perineal body itself that's attached to the EAS. Like there's a lot of areas, there's a lot of tissues within that small region that can be the pain generating tissue. um, so on one hand, we have to completely 1000% believe what a patient is telling us because that's their experience. And also understand that we don't have very good 2 point discrimination down there.
Yeah.
Patients don't really know what to say. They know pain, they know pressure, they know
Yeah.
weirdness, right? But they don't necessarily know, like, oh, it's coming medial to my ischial tuberosity. Like, that's really what I'm feeling. So
Yeah.
it's also important for us to make sure that we're evaluating really specifically some of those structures there to make sure that we can actually identify, is there a pain generating tissue here that's local, or is it also a central problem
Mm.
that the pressure on that, on those tissues of the ischiorectal fossa is actually creating a fear around sitting or pain or pressure in that region. Then now we have to look at central mechanisms for that hypersensitivity of that tissue. But it all comes back to us assessing there and deciding what percentage of that is, what percentage of their symptoms is actually coming from the tissue itself versus something else around it versus a central mechanism potentially.
Well, I want to talk a little bit more about the role of the pelvic floor muscle function and the IRF because I want to
Okay.
just share this what happened for me in the clinic after I listened to your podcast, after I explored like what's this IRF and got curious with it. I had a client that when she contracted her pelvic floor muscle, as you palpate back, it was like 3/4 there was a divot, as you move your finger back across the floor of the muscle,
Okay.
you going across, and then there's a divot, and then it comes taut again, right? So whenever I see or feel those divots, my first thought is, oh gosh, is that a defect? Did the muscle, the belly of the muscle that is not contracting, it's staying deep, and everything else is lifting up, is that torn away from the attachment point, and then you're like, oh crap, right, for the client.
Right.
And so I had felt this on this client, and I was just like, oh darn, because I could not feel it, in that divot there was no muscle activation. Okay, so went on and I worked on her EAS because postpartum, anybody who studied with me, you have to treat the EAS after having a baby because the babies just cause so much tension and knots in that EAS. And since listening to your podcast, now I'm like going over and checking out that tissue distensibility between the perennial body EAS and the ischium, and it was really restricted. And so I just worked on encouraging and getting that tissue softer in there. And I was blown away, Nicole, when I went back in and I reassessed the muscle, there was no more divot.
Yes.
I
Yes.
was like, holy crap. So my sense is like that restriction was making that muscle inability to contract at all. So
Yeah.
have you
I
experienced
would
that or?
absolutely. Yeah. And I kind of think about it akin to, if you think about a different muscle group, right? And which I see a lot in the adductors, actually, right? If you're not assessing the adductors, there's another place that you need to be looking at. And the adductors actually have some attachment points up to the ischial rami, right? So this is all where some of that stuff can also influence the ischiorectal fossa. But that being said, you know, there needs to be good slide and glide of the fascia over a muscle in order for that muscle to be able to expand and contract, or elongate and contract underneath that muscle. So we understand that
Yeah.
in pretty much everywhere else in the body. It's one of the reasons why some of our manual techniques and or stretching and things like foam rolling and all that stuff is all based on helping those tissue areas slide and glide more so that everything's healthy, because good blood flow. underneath in those different layers, right?
Yeah.
So the ischiorectal fossa is another area where some of the superficial pelvic floor muscles, like so superficial transverse perineal, the external anal sphincter, a little bit deeper to that is iliococcygeus,
Hmm.
and some of the levator ani. And so if there is dysfunction over the superficial parts of those things in this ischiorectal fossa space, then it can restrict blood flow to those muscles underneath. Those two things can get essentially stuck together and not allow either a proper lift or contraction or a proper elongation for things like defecation and pushing out a baby. Um, Things like being able to adapt to intra-abdominal pressure, like with a cough,
Yeah.
right? So we need to have a little bit of that give in that way. And if there's something that is in that superficial space that is impeding that, or that is not allowing that the distensibility to happen, so if we think about like where the superficial like connective tissue structures are, they have to be able to expand and elongate during defecation and baby and even load intra-abdominal pressure like cough. Um, and so if we have dysfunction in that space, it can significantly affect the musculature underneath that, either from a physical problem, right? Like it doesn't allow expansion, or just a blood flow, health of the tissue issue as well. And so we have to be looking at that as a possible um, contributing factor to any one of those areas of the underlying muscle not being able to do what it needs to do because of that superficial restriction, just like we see sometimes in the adductors or any other part of our body. And the one other thing I'll say too is that so sometimes I'll assess it like I described with my pushing my thumb in just to get the the differences side to side to
Yes.
see, ooh,
Yeah.
is it painful, and or how much depression do I get from that? But a lot of times, Lynn, the treatment is actually a lift away of the tissue. So I'm actually thinking about pulling that tissue away from the ischial tuberosity, almost like a creating more space in those areas. Because if you think about it, if those bands of connective tissue are taut and not extensible, we want to help them to elongate and create more space in that region so that it's not compressing any arteries or veins and restricting any blood flow in and of itself. So there's a lot of techniques where I'm actually pulling that connective tissue towards me as the clinician, versus pushing it
Yeah.
in,
I,
to do just like lifting, the fascia away from the adductors. Or if you think about a C-section scar, right? A lot of times we want to lift it away and create more space underneath that area. So those are the same kinds of concepts that I'm thinking about when I'm treating in that area as well.
yeah. I'm a big fan of compression, and I know you know, like, but what I find is that like that stuck drawer, if I push it in, then it allows it to come out, you know? So
Yes.
sometimes I find that if I'm compressing in, and I'll even use I love using the bones. I truly believe we shouldn't be working on the pelvic floor muscles without having our external hand on the bones, depending on what muscle we're working on. But really compressing the ischium medially, and then yeah, and then finger, usually my index finger is in vaginally, and then my thumb will be more in that space, and then just compressing it all together, and then you just feel this like beautiful like melting away. So
Yes.
love that we have so many different options when it comes to our clients, and I would just encourage people listening, and like you just heard Nicole say stretch and pull away, and I said compress and push in, and you listen to the client and listen to the body on the table to see what you feel like that body needs to
Yeah.
get.
And to your point, Lynn, though, I feel like whenever I have my hand in and around that area at all, whether I'm internal vaginal or external, the other hand needs to be doing something as well. So to your point, whether you use the same things like we learn in with visceral, like that approximation, sometimes approximation of different tissues that go into there, which is why anatomy is so important, right?
Yes.
So if I'm at the ischiorectal fossa and I know that the adductors also have a role in those things, I might have my hand on the ischiorectal fossa and slack the adductor fascia and then see if that changes at all, right?
Oh,
So again, it's a little bit of that impressive thing that you were talking about. I call it approximation, whatever. But bottom line is using the different tensions that you can relieve on that area to feel what's happening underneath your hand. And then we can do some rotational components of that structure. We can maybe do a little distraction. Maybe we do need to compress in a little bit more.
yeah,
But at the end of the day, we're looking for what is giving the best release of that patient. We
yeah,
can even look at what does the hip angle need to be doing at that? Do they need to be in a little bit more abduction or a little bit more adduction? Does it need to be in hip
yeah,
flexion? There's also capabilities for you to and when I say this, I don't want you to think of it as an aggressive technique, but there's a technique called that we kind of know about tack and stretch, right? So you can hold that tissue and then you can move the hip
yeah,
so that you can kind of see like where do we actually feel in what hip range of motion, maybe in this instance, flexion. I have my hand medial to the ischial tuberosity. I'm actually feeling what happens to that tissue. When does the tension start to build up? I go into hip flexion. I pay attention to what angle that is. And now maybe I back off a little bit. And now I'm doing something with that tissue from a rotational component going into the area of ease, or you can also go the area of other way, but I usually go in the direction of ease first.
yeah.
Can we move that hip into more flexion by changing a little bit of the direction of ease of the tissue in a different rotational component? Sometimes yes, sometimes no, which means, so you just play around with that tissue to get the best release.
And what I'm hearing you say, Nicole, is that you're evaluating what's happening underneath your thumb that is on the ischiorectal fossa
Yes.
while you're doing all these things to see what makes the greatest change under your thumb in that area.
Yes.
So whether you have your
Yes.
hand on the adductor, whether you bring hip into flexion, and this is where I think we talked about this in my interview on your podcast, your intuition is what can
Mhm.
be guiding you as you tune into these tissues. So what I like to teach is like feel that ischiorectal fossa, feel the tension in there, and then get a sense, where do you feel that pulling coming from? Does it feel
Mhm.
like it's getting pulled down from the adductor? So, like let me put my hand there first. So if we can tune into these tissues and get a sense of what am I feeling other than just, oh, it's tight, like, where is it tight? Where's that tightness coming from?
Yeah, I love that question. And I ask those questions to myself a lot as I'm treating, right? And there's a lot of times too where have my hand there, I'm sensing some tissue tension happening underneath my finger, and I'm like, anatomically, it doesn't really make sense why that would be happening. So
Right.
now I'm like, okay, is it coming from further back or is it coming from further front?
Yeah.
Sometimes I'll have put my other hand underneath that person's sacrum, give a little bit of a
Yeah.
sacrum
Yep.
TA, right? One sided. And all of a sudden, something that you wouldn't even think is
Yeah.
necessarily like connected, all of a sudden something releases there. And now it's like, cool. And now we can start to think about, well, why did that work? Or from when you were on my podcast, we talked about what position is that sacrum in? Is that in a freeze state from a position, an open birthing pattern, using your, terminology, or is there is there another biomechanical reason for that?
Right.
Or is it just we gave another input to the nervous system
Right. Right.
that
Sometimes it
allowed
makes
that area
sense,
to be feel safe? Sometimes it makes sense and
and
sometimes it
sometimes
freaking
it
doesn't.
doesn't.
And you know what? Sometimes you just got to go with it. And at that,
Right.
but you're not making shit though. You're actually feeling. And to your point, Like it's not so in that way, I kind of call that like an indirect technique.
Uh-huh.
So where I'm feeling what's happening and I'm treating in another area to see what's happening there, versus the other thing that I described before would be more of a direct technique where I'm actually, manipulating the tissue at the ischiorectal fossa itself. And for some people, they respond better to those like direct techniques.
Mhm.
And for other people, especially some people that are more hypersensitive or maybe centrally sensitized, they do better with just my hand there, and I'm treating in another area that feels more safe to them than the actual area.
So, Nicole, how do you decide what you're going to do? Direct or indirect?
As a rule of thumb, well, when I'm teaching, I usually will say, what I usually will say is, I think this quote safer way, the thing that tends to flare people less or just be a little bit more accepted by the body, I usually would teach indirect first, where you're really placing your hand on the ischiorectal fossa in this case, but I teach this sort of everywhere, and then move the other tissues that might be anatomically connected and see what happens, and then go with where you feel like the best release is. So in that way, I feel like an indirect technique is best. When I'm actually treating for myself, there's a lot of there's a lot of intuition that goes into that. There's a lot of assessment of irritability of the tissue. There's an assessment of the person in front of me. Um, you can do an indirect technique on somebody and they're like, what are you even doing? Right? Um, what is this voodoo stuff? Like, I don't even feel like you're doing anything, to me. And if that person needs a little bit more input to their system so they can actually feel like I'm doing something, I still want to be cautious around what I'm actually doing to the tissues. But if they need to feel something, like there's also a way that I can engage the tissue more directly and then use another technique to sort of mobilize that tissue underneath my thumb still. So in that way, I'm assessing both the person in front of me. I'm assessing what do I feel like this tissue actually needs. And I'm also never forgetting to go back to anatomy and physiology of the areas and looking like, what are the other structures that could be involved in this pattern that I'm seeing, or this tissue tension that I'm feeling? And does this matter for this person? Because I will tell you that there's sometimes where you feel the ischiorectal fossa and it's like, feels a little bit more taut than my 7 other patients that I just treated today. Does that matter for that person? And does that correlate to their symptom presentation? Sometimes the answer is no.
Yeah, when you're assessing that IRF, for you, is it just that uh pressure in pressure like what we pressure into the body like towards the head if we're hook
Right.
line, right? So is it just the pressure and are you comparing one side to the other side? I guess we could have it where both sides are tight.
Mhm.
So
Yeah.
what is a normal assessment of the IRF versus abnormal?
So this is a great question. So I will always assess bilaterally, right? And I will start to piece together the patient's story in my head, both from what they've said to me subjectively and both what I'm feeling objectively. So just to give you an example, so let's say I somebody has a history of right hip issues, right hip pain, right? They've been diagnosed, quote unquote, with trochanteric bursitis or something like that. They have a little bit of lateral hip pain. They also maybe have dyspareunia, um, and so I might start to feel that oh, does it? So I might anticipate. I always like think about having a prior
Yeah,
based on what they say. I feel like I want to know what am I anticipating I'm going to find.
right.
Let that completely dictate what I'm doing. I try not to bias myself that much, but I do need to have a prior so that I can say, to me, it feels like I might anticipate that their right side of their pelvic floor is more tensioned. I might feel like their right side of their ischiorectal fossa is more tensioned. And then I go in and I assess both sides, and then I'll see, does that make sense? Is that helping my story? Or And this is equally as important. Did I not feel that? And if so, why might that be the case? Now do I need to create a different
Yeah.
sort of story in my brain about like, whoa, ooh, interesting. I expected this. I didn't find that.
Right.
And now where do I go from here?
Yeah.
Um, so I don't know if that answered your question really, but I feel like I assess bilaterally. I do both. I do both a sort of sink my finger or thumb into that area. I also lift and pull away. I also might do a little bit of like a rotational, like as I'm pulling away, I look and see what happens if I rotate. Because remember, that area is subject to a lot of different forces. It's subject to both the pelvic floor going out for defecation and then up and in for a pelvic floor activation. It's influenced by both the transverse and the frontal plane of the hip motion and really sagittal plane. So all the different planes of that. It's affected by tension on the adductors. It's affected by tension in the glutes. It's affected by what the pudendal nerve is doing, by the posterior femoral cutaneous nerve of the thigh, and the genital branch goes right along there and kind of inserts up into that region. So as I am assessing those areas, I'm also thinking about all of the different things that could potentially be an issue. And does that correlate with any of the person's symptoms, both from a prior to their symptom onset, but also after their symptom onset, what is happening? Susan Clinton, I was talking to her one time, and I loved the way that she put this so succinctly. There's a reason why the patient symptoms are there, like what got you here, and also what's keeping you here. And so I always try to put in those two concepts of, is what I'm feeling something that I think has been there for a while that contributed to the symptom onset? Or is this tissue dysfunction a point at which now we're sort of in this like spiraling loop of, you know, in this case, we're talking about the IRF. So it's like subcutaneous paniculosis, inflammation, pain with sitting, that now that loop is there, right? And so what do we need to do first? Do we need to address the why, the what got you here first, or do we need to get you out of this cycle that you're currently in that's creating this symptom presentation, and then we can get to what happened before? So
Yeah.
those are some of the things that I'm thinking about when I'm actually assessing this tissue.
Okay. But so you're going in and you're pulling out and rotating a little bit, but no like I guess it would be AP, like toward pubic bone, towards the floor, like up and down kind of motion.
Good question. So yes, and this is where I feel like the phrase "skin rolling" gets a little bit bastardized. I think with the way that we have been taught it. I literally I don't think I've met a person that I've trained that does skin rolling the way I think it should be done.
Yeah.
It's either too superficial or it's too deep, but we're not actually assessing like the tissue that we need to. But I will do essentially what I'll call like a sweep of that tissue too, where what's the best phrase? I know this is like on a podcast, but I sort of will take my thumb and sort of
Pull it
not
down.
drag it, but pull it down. Yeah, and just sort of see what that tissue excursion is. I
Yeah.
will also try to take, this is where I feel like going from like anterior to posterior, but also making sure that it can move from posterior to anterior,
Yep.
right?
Yeah.
That is also equally important. So from that perspective, sometimes I'll put someone in prone and go from like where EAS is down towards the
Uh,
table
yes.
to
Yeah. Yeah.
assess that same way,
Uh-huh.
right? And then if they're in supine hook lying, I'll take it from like where superficial transverse perineal is, and I'll assess its ability to go down towards the table in that way.
Right.
So
Yeah.
you're assessing both directions of movement. So it's both compression, it's both distraction, and it's both, does that tissue move in the areas that it needs to move?
Yeah.
And it also needs to move out and in as you have adduction and abduction. So it's a really
Dynamic
cool
spot.
space and
Yeah.
dynamic spot. And it's like a crux of hip motion, sacral motion, pubic bone, perineal body, EAS, pudendal nerve, like all of it,
Yeah.
right? So it's a lot of other times too where For someone that has maybe pain with sitting and you're suspecting penial nerve irritation, I teach to palpate along the path of the penial nerve. And I feel like a lot of times we stop at Alcock's canal and forget that the penial nerve actually comes out of the ischiorectal fossa and branches into its three areas. Some people will say that the inferior penial nerve or the inferior rectal branch of the penial nerve actually branches before that. But be that as it may, there's still ways to assess that superficial uh, area where it comes out. And while we're doing internal, we are like so easy. We're like, okay, cool. It comes from sacral plexus out. We need to do assess between piriformis and coccygeus. We need to assess that ischial spine. We need to assess Alcock's canal, and we stop. But we need to also remember that there is an ischiorectal fossa component to where the penial nerve travels, both for things like incontinence, right, and the other ways that we need the pelvic floor to recruit, but also for things like pain with sitting, uh, defecation disorders, and also like anything with the perineal body not being able to move up and down.
Yeah.
So,
Wow.
so
And
important.
and then also, I mean, think about the scar tissue from tears and episiotomies.
Yes. Yes.
Duh.
Dude, yes, duh, right? And that's the kind of stuff that's like can significantly affect this
Yeah.
tissue, right? And so we know that episiotomy automatically cuts through the superficial transverse perineal and probably bulbo or ischio. And so it's like we already have muscular stuff, but in order for that to heal, we have to have the tissue on top of that also be healthy as well. And part of that is ischiorectal fossa,
Yeah.
right? Um, yeah, so obviously tears and episiotomies are huge areas where, and I think this is where like that's a little bit more almost obvious. Like when you are working on the perineal tear scar,
Yeah.
you are adjacent to, if not in and on the ischiorectal fossa area. So you might already be working there. I just want people to do a thorough assessment of that entire structure.
And,
Um,
and I would say even going more laterally, Nicole,
yes,
right?
totally.
Like let's get off just the scar tissue because I mean, oh, the impact scar tissue has on that entire area. Um, I sense that that scar tissue can travel up that vaginal wall and start pulling on that interior vaginal wall. And so we got to think beyond just where the actual scar itself is,
Right.
and it's going out and then, for me, post birth, when I do find the ischial splay, the issue, depending on how baby comes out, one ischium can be more splayed out to the side. You talked about me mentioning that sacral flexion too. Like if someone is in this ischial splay sacral flexion, that IRF is on tension.
Tension. Absolutely.
And then we have
Yes.
scar tissue, and but I'm like, that area needs help, everybody.
It needs help. It needs, and I think if you go back to the basics, to your point, Lynn, about tissue healing, but then also areas adjacent to that tissue that also need blood flow, and just good mobility in order to heal best, then that should be a part of your assessment for anybody that's torn even a little bit. Even a superficial tear, by definition, is very much adjacent to this area that we're talking about. Um, and I think it's just super important to remember that as a potential this direct pain generating tissue, but also a tissue that needs to have good health, both from a blood flow perspective, a lymphatic perspective, um, in order for everything around it to be functioning optimally.
Right. Oh my gosh. This has been so juicy. Is there any last tidbit that you want to make sure that we cover before we say goodbye, Nicole? Thank you. This has been amazing.
I feel like I can already hear people being like, right, but I need to see that. I need to know how. And I would really encourage you all to go back to your anatomy and actually look. It's in Netter, like there is an area, and just look at the cross-sectional area of where the rectum, pelvic floor, adductors, ischiorectal fossa is, and just start to think about that in the context of the entire pelvis. And I think, once you go back to those anatomical and physiological basics, you'll be more um, brave, I think, in not having to see exactly what I do or exactly what Lynn does, but be more brave to just assess the tissue from an anatomical perspective and try to put the pieces together for yourself. So that would be my last sort of parting words, is that don't be afraid to palpate around this area and just be a little bit systematic about how you assess it from side to side, from anterior to posterior, and just start to do it in almost every single one of your patients. There's literally, I cannot think of any person, minus the person that just doesn't want you in that area at all, that actually doesn't consent to even an external exam. But minus that type of a person, there's literally nobody that won't benefit from you just assessing this tissue as a component of, is this tissue a, a problematic in the context of what this patient is feeling?
Yeah.
And anybody, prolapse, incontinence, pain, dental stuff, I see literally
Yeah.
any place.
Weak pelvic floor muscles.
Yeah,
And start by comparing side to side. Like start there. If one side
yes,
moves, the other side should move equally to the same extent. Now,
yeah,
there is a difference if both sides can't move, but we're not talking about that. Usually when there's an issue, it's more one-sided. Listen to the symptoms and their complaints. If that symptom and complaint seems one more sided, then really assess left side to right side and see if you notice a difference in these areas. And then, like what Nicole and I talked about here, just play around with it and see what causes it to let go.
yes, yes. And please don't be afraid to just try stuff. Like I feel like this is the blessing and the curse of listening to podcasts like this, is everyone's like, oh, sounds so awesome, but I need to know exactly what to do. It's like, no, you don't. We just told you, we
Right.
gave you the permission to assess this in your patients. And if you have specific questions about it afterwards, you can, reach out to Lynn and I, whatever, go
Yeah.
into any of these Facebook groups that you have one, I have one, like whatever. But at the end of the day, like, it's okay to try stuff on your patients, and I just want you to do it on a lot of people, so you can start with your
Yeah.
to get like, oh, for this, you can start with your reps to be like, oh, for these types of people with these types of symptoms, I'm commonly seeing this thing in the clinic. And so then you can start to use all the techniques that you know externally on how to treat anywhere else in the body. You're just applying it to this area.
Okay, so Nicole, I have one last question for you, and I seriously would love to just talk to you all day
I
because
know.
it's fun. Um, I, when I teach, I'm a big proponent of respecting the tissues and not creating pain, especially in this area. Now, with that being said, I do not treat a lot of pelvic pain. Like I
Mhm.
don't see a lot of IC and VV and all those, pelvic pain syndromes in my clinical practice. So I'm mainly pregnancy postpartum. So I want to preface this. But how does that statement land with you? Like because you do deal more with IC and all the things. So
Yeah.
what is your stance on creating pain when we're working with our patients?
Well, here's the thing. I do not think that we should be creating pain to treat pain. So, and this is something that I've changed a lot in my practice. I used to kind of be like, whatever, it's going to be sore. We need to just work through it. It's okay, kind of a deal.
Yeah.
And now I am much more respectful of the, just like you said, much more respectful of the tissues themselves and the pain perception that is going on for that person. Whether I feel like the biggest thing for me is that I will, in my head, anticipate what the patient would say in terms of like, how much discomfort are you in when I'm touching here, right? So I'm assessing the tissue. I'm thinking to myself, taking into account their personality,
Mhm.
their symptom presentation, their fear avoidant behavior potentially, their, you know, all of the things, and how the tissue actually feels. And I try to anticipate what I think they would say if I asked them on a scale from 1 to 10 how much discomfort are you in with this? And I really try to stay um like 0 to mild, right? So
Yeah.
maybe on that scale, like a 3 or below,
Mhm.
nothing that creates a fear, a tension, protective thing. So, but that being said, when you're dealing with somebody that's already in a lot of pain, sometimes it's very difficult to achieve any sort of touch that's not painful,
Yeah.
right? And so this is where it just goes back to clinical judgment on, does my patient need some sort of intervention to calm their nervous system first before I go into this? Does someone need me to do something external before I go internal? Does someone need me to assess like the state of their nervous system so that my touch in that region won't be perceived as a threat? That's, I think, some of the most important thing to do. So to answer your question, I think that in a perfect world, we wouldn't be creating any pain with any of the interventions. In an imperfect world, which we all live in, sometimes it's going to be a little uncomfortable, but I talk my patient through that. I try to make it help it to not go above like a 3-ish. And if there is some discomfort, I try to name it. What is it? Not just that it's pain, but is it pressure? What is it? And then does it dissipate relatively quickly? And if it doesn't dissipate relatively quickly with my intervention, then I get off of that area.
Yeah. Okay. That's so important because we know it's a hot area that's not.
Right. And then we got to look for something else in order to help that tissue to relax and release better.
Right.
I don't just keep going at that same thing and hoping that it will eventually like let go. That's honestly, that is what I used to be a
I
little
know.
bit more heavy-handed like that, and that
Yeah.
is something that I've significantly changed in my practice because it doesn't work.
Right. Yes.
Because it
It
just
does.
doesn't, and it doesn't do anybody any favors, and even if it does it something in the short term, it's definitely not good for the nervous system long term, and
Yeah.
it doesn't build any trust between you and the patient. So it's really important to be I love that phrase, respectful of those tissues.
Yeah, I think younger clinicians, so those of you listening in that are newer to the field, um, just learn from Nicole and my experience over the years. Creating pain to treat pain rarely works out well.
Right. But yeah, it's very, yeah, I can think of 0 people where
Right.
that's actually
Well,
where that's actually been like, oh, that actually is an exception to the rule. I'm like, in this case, I feel like there is no exception
well,
to that rule.
see, it's almost like when they've created pain to treat pain, it's like the pain always comes back worse.
Totally. Or different or something. Yeah. Or it's just not conducive to like long-term healing.
Right, right.
Even if your patient is saying, but I don't feel anything, right? And it's like, then you just have to get good at saying, I know that you want to feel more. And I promise you, we will once we get this tissue to be less irritable. But right now, that threshold's got to be less than X amount. And we talk about what that means and why and stuff like that.
Yeah. Oh, so important. Respect the tissues, everybody, please.
Yes, please do.
Awesome. Nicole, is there anything that you want people to know or to check out that you have going on right now?
You
Other-
know, not particularly. I just, if you want to get a hold of me, I'm on Instagram at Nicole Cozean DPT. That's one of my clinician-based stuff. If you're interested in what we're doing at Pelvic Sanity, Pelvic Sanity is my clinic. I have Pelvic PT Rising courses, business coaching, all of that. PelviCon is sold out for this year, but um, there will be a virtual option. So just kind of stay tuned for that. Otherwise, I'd love to hear from you guys. And if this has been helpful at all, reach out. Thank you so much, Lynn, for having me on this podcast and being able to talk about something that I'm so passionate about.
Yeah, I reached out to you right after shortly after that podcast and I went, "Oh my God, can we do a podcast on this, please, Nicole?" I'm so glad we finally got around to doing it. So
Same. Thanks so much, Lynn.
incredible. Thank you so much. Appreciate your time and sharing all your wisdom with us. So, thank you everybody for listening in, and we will see you all in the next podcast. Here is to smoother births, faster recoveries, and checking out those IRFs. Thanks, everybody. Bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.